very easy, as Fraser has already explained really, to have used the available time to put in a series of other talks. But I think that a meeting such as this, a further direction in one direction, only from here to you, is actually rather outmoded. So I think it's really important to take some time to get your feedback. And Claire, who's walking around the room from Dovetail, has been instrumental in arranging this. I think her and Fraser are going to lead this later part. I might involve the other members of the panel, actually, just to walk around the tables and to participate in some of the discussion. Claire, tell us a little bit about what you want and how it's going to work over the next few minutes.
What we do is get your input. So because we've deliberately sat you in cabaret tables, so I'm deliberately only giving you one copy of this document of the draft reports that Mark has developed. And we'd like you to discuss them together and get some consensus. So if you're standing up the back, you're very welcome to come and join some of your colleagues. We've got about 15 or 20 minutes, so we've got time for you to have a good look at the reports and just jot down your thoughts to say what you like, what you don't like, what you would change, what you'd add. As Fraser pointed out, what would you need for appraisal reports? Anything else that you'd like involved. This is, as Keith has said earlier on, it's really your chance to be involved. It's a group project, so we really value your input. Now's your chance to have your say. And we'll give you, as I say, sort of 10 or 15 minutes to look at the document in groups, discuss it with your colleagues, and give us your consensus. And then we'll collect back the documents and feed them into the panel discussion. And Mark will take them back to the BSG and implement everything that you want. That's feasible.
Do you want one person at the table just to summarise those?
I think we could do. If we've got, in fact, we could do that if we've got time. We could feed into the group, into the panel discussions. So if there's some key themes that are coming up in your discussions and you want to feed them back to the panel, then we can do that in the discussion. Is that clear?
I think we've gone around each and asked every table just to nominate one person to stand up and give us a couple of bullet points. I think Fraser and Claire can mediate the questions or the comments coming up from the tables, and then we'll move into a little bit of panel discussion.
Great, so we're going to start with this tables at the front who have been picked on, I think, by Claire.
What we were looking at was actually although it looks nice to have these reports, can they not be built into the system so that it can be generated straight away, which would save time and also allow you to then give data comparisons across different sets without having to do further Excel work, which some people may or may not be able to do. I think it was mentioned in the talk, but is there going to be benchmarking available so you can compare your performance to other people? I'm a UC patient. My question was, can we leverage the patients to help input this data? Because it's a huge data entry task, and I think a lot of you are sort of going, how the hell are we going to do this? I would certainly be happy to input my data. I'm sure we can mobilise a lot of patients to do the same, whether it's in clinic, in a biologic clinic, or even at home. I don't know the logistics of that, or there's some barriers to overcome, but I'm sure it would save a lot of time. And there was also a question of sort of cost, I think, from the table and how that works. And the final question was, what is the barriers stopping this from happening? And that's sort of personally, I'd like to know that as well. Just what can we do to help?
Thanks very much. A few really important questions there. Just in terms of patient involvement, which I think is a really important key, important question. Richard Driscoll's been working really hard on this recently. Is Richard still here?
Just stepped out of the room.
Great. It might be best if he speaks to it, because he's been doing some work with Helen Terry, who I can see sitting here, about the possibility of using IBD patient view as a mechanism, that might happen through something. Would you mind if we moved on to a few comments about the report? So real-time reporting and comparison against national standards, I think, were the 2 points in terms of the data reporting. And those are both sort of planned, so I think they're really important comments as well. We'll come back to your other comments in a bit, if that's okay with you. Now, over on the mic.
So we liked the look of the reports generally. We thought managers might need some support in terms of explaining what the data meant to them. Would we like to see more or less? We thought it would be useful to have some tools to pick up some of the perhaps adverse events where things haven't gone so well, in terms of emergency admissions or treatment failures, or indeed where people are DNAing. Because in many ways our sickest patients are the people that don't comply, continue to smoke, and then turn up really sick. And picking up their DNA would encourage us to follow that up more aggressively. Similarly with the monitoring, people not complying with monitoring, if that could be kind of red flagged or alerted. We would use the tool certainly. In terms of would we use it in conjunction with our other applications, I think the big challenge, certainly where I work, would be that our IT departments struggle to integrate anything from the outside world. We're still working on Internet Explorer 2003 for our patient record, and it doesn't actually work on any of the new websites. We like the look of the report. Things we'd like to see more of, perhaps something more about people's presenting symptoms and their ongoing symptoms, something more about patient experience and how patients felt about their experience of the service, and perhaps a bit more about comorbidities, particularly if they're gut related. So lots of patients with IBD have IBS, and it would be useful for people kind of coming into the database new to have that flagged, so they knew that when the calprotectin was normal and they got pain, it might be their IBS. Brilliant, thank you.
This is good stuff. I don't want to interrupt the flow too much, but there is a very important point that's been made at the back of the room as I've been walking around by Rafiq, which is to say that while the majority of physicians and clinicians here are adult-based, this is a project without age boundaries, which means to say that it includes paediatricians and paediatric units from around the country. In fact, they have contributed an enormous amount to the requirements and design of the tool. So yes, we do value the contribution of the paediatricians, and their involvement is absolutely crucial to this. So thanks for making that point.
Now, who's next? Brilliant. Comments, please.
Well, does the microphone here?
Thank you, Dr. Sauer from Grimsby. We have already registered with and basically we are in the process of transporting our data. In general, this report overall seems very good. I was just wondering, there are some inter-consultant variability in practice as well. Whether something could be got out, say, in trust, one trust, there are 4 consultants, and they all practice IBD. So could we get some kind of some form of report which can basically give some feedback in positive way? That was my.
And by that, do you mean sort of consultant-specific reporting, or?
Yeah, maybe. Yeah. And the other thing is, what help and support the trust will get in terms of transporting the data from biologics audits to the IBD registry, and when this is going to happen.
It's an ongoing process that happens on a quarterly basis at the moment, so it's not a one-time event. You're talking about just uploading data, local data up to legacy.
Or use the legacy biologics?
That is a process that has been built into the transition phase, and the software provider is planning to import that data. That's that's ongoing. It's planned for the next few weeks.
Next quarter.
Yeah.
Now, I wonder, could I pick on Elaine or Helen to maybe give some comments from Colitis UK or David on that table? Yes, I'm looking at you too. Trying to look around and see if there's anybody behind you. Fortunately not. Anything you'd like to say?
Yeah, can
David.
I make a point on behalf of Crohn's colitis?
Pardon?
Can I make a point on behalf of Crohn's
Of course you can.
colitis?
Of course you can.
Is there any point when you enter new patients to say, have you told them about Crohn's colitis UK? And is there any point at which you report whether they've joined Crohn's colitis UK? It's always one of our concerns that only about a tenth of people with IBD are members. And I don't know what proportion of doctors actually prompt their patients to join.
Very good point.
Hardly any, to be honest.
Yeah.
Well, it might be something you can put in on that.
Our practice is we have your patient information pack, and if you have a brand new patient, we give them that.
Yes, so do we, but it needs to be recorded.
But
Needs-
yeah, so
This could be an opportunity to prompt
A
doctors
tick
to do
box.
it. Owners, yeah.
Can I just make a plea for people to use the microphones just because we're recording the session for posterity? No, I don't want to miss any of these gems. Thank you.
Sorry, I wasn't sure, Ian, are you asking us to comment on the reporting or just a more
we were
generic?
asking you to-
I couldn't pick up a report
reports
just
in the
made
first instance.
earlier about patient data, so I think one other question I had for you, which probably is not related to the reporting, is what is the role of patients within this? Because I sat in on a session yesterday, an excellent session, where patients were making a real difference in terms of driving quality improvement and a whole load of other things, to all the wheels. So I think there's a number of things, but what would be interesting to get the panel's view on, which may be related to the reporting, I don't know, is what can we do as the national organisation of patients, but also how can patients help people locally to unlock barriers, to really drive. That's a really important question which we had down as a part of the panel discussion. So can we finish the reports room tables and then come back to that, because I think it's crucial to address.
Okay, so now, Helen, did you want to say something?
Just a very quick comment really, but I'm thinking back to this session last year where we had a patient, Ross Prescott, here, and actually Ross and many patients are surprised that this isn't happening anyway. The level of data, the lack of data actually is quite surprising to patients. And one of the big issues is around the continuity of their care and having to repeat themselves again and again. And this is something that could really enhance the patient experience, but we need to be able to communicate that better to patients, I think. I think patients could be one of the real drivers of the implementation of this.
Thank you very much. Now, Phil, from an industry point of view, because industry may find the registry very useful in future in terms of data, some of the things that Fraser was saying. From an industry point of view, what would you want out of it?
I think we were kind of really concentrating on making a point at the start of that, was a lot of the diagnostics that you go through. And one of the big things that I'm able to put some arteries and things that are missed and not treated. And that's very much about patients who are treated in some systems. Now, early actual standards of testing at the beginning of what people are actually looking at, what people are seeing.
Now, can I ask the table just right and to the back if you had any comments?
We spent quite a lot of time focusing on individual tables provided.
Absolutely.
So obviously there's a lot of general comments to be made. I think something that came out was regarding quality indicators for acute episodes. People get admitted, particularly those going for surgery, whether they've seen by a dietitian, whether they've seen by a stoma nurse, etc. before, whether they've had their C. diff, stool MTS is checked. Those kind of things that were measured in the IBD audit previously.
Yeah.
So you can demonstrate that you're delivering good quality care for the acute episodes. In terms of the medication output, percentage time on steroids, you're recording that, but you're not saying how long the history of the diagnosis is. So if you've been on steroids for two months, but you've only been diagnosed for a year, that's different to being on steroids for 2 months, you've been diagnosed for 10 years. So felt that there could be further information given about that in terms of medications. Likewise, there'll be a prompt for patients on anti-TNFs for their annual colonoscopy to assess disease activity. Is that going to be? That's going to be in there. I think it's probably mainly it.
Great, thank you. Yes.
I'm writing an improvement.
We can look at our tables in a little bit of detail, but just a general point about the quality of the data going in. Somehow, once it's been recorded in days or weeks or whatever, it assumes a sort of a reality which may not be correct. A good example is the time from symptoms to diagnosis. I mean, it must be just incredibly subjective. And I think here it's recorded in days, which is, we're asking patients to recall something. I'm not sure how much meaning that has. But that also applies to a lot of the other data that goes in. This is being used for research. The question is there any way of validating it? Which is a concern. In terms of the specific things that we looked at, age of the patients in the registry, are those age brackets customizable? Are there ways of, presumably there are clever ways of cutting it different ways. Will there be a Montreal classification output, which will be useful? Gender, presumably that's a mandatory field, because there's a great big thing not specified and missing, but presumably you won't be allowed to have a missing gender when we're putting patients into this. We had death details. We were completely mystified about how it would be possible for most people to record data about death. It's a bit like asking people in the room to put their hands up if they're not present. In reality, is that going to happen? I'm not sure it is, but we've been told that there are ways of getting that retrospectively through HES data, and so presumably that would be something that could be linked in and provided back, and that would be very valuable.
I think that's a key point, isn't it?
Because I can't believe that that people are going to do that much after the patient has died. I would imagine, unless somebody is specifically doing that locally, it probably won't happen. What else have we got here? Data diagnosis to the current day. That's very useful. But you've got a histogram here of duration of symptoms onset to the current day. Well, that's not relevant. It's the duration of symptoms before diagnosis that's relevant. But again, how accurate will that be? Probably not. The details about surgical procedures, very useful, but it needs to be broken down by diagnosis. I can't believe there's any relevance in plonking together all your surgical procedures for UC and Crohn's and unclassified patients together. And the medication extracts, our tables talked about numbers and types of prescriptions. Again, is that going to be every prescription issued? How's that going to work? Surely not. What people mostly will want to know is how many patients are on such and such a drug, how many have been on those drugs previously, perhaps broken down by groups as well as individual drugs, very useful, but also reasons for stopping, particularly toxicity. Clearly, to have some summary figures about that would be very valuable.
Right.
And then lots and lots of other things that aren't here, but we've already heard about.
That's very helpful. Right, time is limited, so thank you for that. That's very helpful feedback from the discussions. I want to take 5 minutes just to have a question and answer session, because there's been a lot of points raised from the floor. We're going to start, I think, with the patient and David Barker's question, because that seems to be absolutely critical, which is broadly how can patients be brought in and help contribute to this process. And I'm going to go around the panel and get some ideas. Pearl, you're probably the most patient-focused clinician on the panel, in that you spend a lot of time with them. What do you think?
I think it's surprising how many patients don't know about the IBD Registry. So informing patients that there is such a thing. And like you said, all my patients are like, well, why haven't you been doing this? Oh, well, that's the 21st century. So, yeah, but they don't know about it. So if if we can tell them about it, then they're going to come in and start asking clinicians about it, because they do, don't they? I mean, I like to keep up to date with what patients are hearing about on forums and things like that, because I know they're going to come and talk to me about that. So.
Richard at the back, I mean, we mentioned just while you stepped out the interest around this subject and the possibility of using patient forums and mechanisms such as Patient Knows Best or IBD Patient View. Do you want to just take a minute to give us a bit of a perspective on what we're doing to address this?
I think there's every possibility of using the sort of trend towards patient portals as a means of enabling patients to enter data. I mean, it works potentially and is being designed primarily for engaging a patient with you as the clinician in their treatment. But if you've got a platform like IBD Patient View, there is every potential for data that the patient is entering, which is useful for their local care, also then being made available through to the registry. I mean, the obvious example would be capturing the IBD control prong, for example, in that would be useful for you in terms of how the patient is now, but having that able then to flow to the registry from IBD Patient View, perfectly possible. It would even be possible to think about an online consent arrangement through IBD Patient View, but it's a question of getting the IT and information governance around that sorted and having the resource to do it at the moment. It's on the sort of, we'd really like to do this list, but we don't have the time or funding to do that specifically. But certainly I would hope that we can align any developments that are happening in terms of the IT infrastructure that involve patients within IBD with the registry and make sure that the different systems actually work together.
Thanks for that. Keith, 2 points that came up within your sphere of expertise. One is validating the data, your comments on that, and the other is Barney's comments about death, and how you can vote if you're not in the room.
Okay, so validating the data, part of the CCUK project is we want to validate what people have put into the registry. There are about 6,000 patients in the initial downloads, so that's what we're working with. We don't need more patients than that to do this validation. And we've got outpatient contacts from HAIRS, we've got inpatient episodes. So we want to see, we're going to do a bit of validation in that sense. So those items of data that can be captured in HAIRS, we'll cross-validate to see whether they exist and cross-correlate with what's included in the registry system. So that's one form of validation that we can pursue. So hospital admissions if they're recorded, surgeries if they're recorded. So we'll be able to validate what's been entered in the registry versus what's been coded. Now there are inaccuracies on either side. So that's as far as we'll get in terms of validating to an external data source. We're also going to do a little bit of work within the project, which is actually consenting patients to scrutinise their local case records and cross-validate with what the registry data contains. So we'll get some sense of that. But of course, that's individual specific. I don't think you can build in a system other than double data entry, or something you might do in the clinical trial, and it's actually quite difficult to do that. What was the second question? Death. Okay, so I think the point about this is, I know I'm slightly concerned about the conversation, because I mean, certainly in our trust we do mortality reviews. It's mandated that every death in the hospital now is reviewed. And it's part of the IBD standard. So the idea that we wouldn't on an annual basis start to have a handle on any patients within our IBD population who have died and be reviewing the background of whether it was IBD related. Well, certainly most hospitals, I think, in England anyway, are putting in systems for mortality reviews. And so this is a system whereby perhaps annually you might track and enter and update the mortality cases, and particularly as an audit drive or as one of the mortality review meetings once a year to review any IBD cases that have died. So if there's a reminder that death is an issue within your IBD registry and one of the members of the team takes responsibility for identifying death, so that's fine. How you do it? Yes, it's difficult. But certainly hospital systems locally now do capture in-hospital death and subsequent death in the community. And so, okay, the registry hasn't got an inbuilt system to facilitate that, but nevertheless, it's a tool to allow mortality to be on the radar and to record deaths intermittently for those patients in the existing registry. So I think it's a potential to support mortality review.
Good.
When the data extracts are done, one of the reports is it highlights when things are missing, when detailed registry items are missing, and that came up for me. The death details obviously weren't there because we hadn't previously had them highlighted, but then So I had a list of 3 patients. That wasn't too onerous to then go and find those 3 patient death details, actually. And I did it at that point, at the point of the extract. That's once every 3 months. You know, just cleaning up your data, I suppose.
Time's getting on, right?
Because I just had to add one thing, because I had a conversation with John Rhodes. I think maybe we haven't communicated sort of the breadth of the data collection potential. For the biologics transitional audit project, some selected KPIs have been chosen, but the potential data that can be collected on those patients, including both the short-term prom and a long-term 12-week review, is all in there. So that those value-added things are collectible.
I want to take 2 questions from the back of the room. Catherine Edwards had a question, and then Tarek Ahmed, and then John. Okay.
Thanks very much, Stuart. It's just a comment, really, thinking about implementation and leverage. Our paymasters are the commissioners, and in many trusts now we're having to use electronic blue tech forms to initiate treatment. I'm wondering whether there's a connection, because effectively the data is the same as your biologic entry page, and it would be a very key driver for usage if the registry initiation form for biologics could in fact take the place of the blue tech form, or at least be interchangeable at the back end of the systems. Just a comment.
I don't think we've got time to come back on that, which that's been posed to us before, hasn't it? Is there an easy answer to that?
But I think that the key thing is actually how the data entries hard to spot data.
Tarek Ahmed at the back of the room had a question.
Yeah, just 2 quick things. One is about whether it might be possible to have iPads, certainly in the infusion units, if people can collect their HBI data, but also in the clinic while they're waiting to be seen. Is that something that we could use, just in the same way that we use iPads for clinical trials or similar devices?
There's absolutely nothing stopping local initiatives of that sort, and we can learn a lot from it. I think that's entirely possible.
Yeah. Okay. And the second issue regards the use of patients' email addresses and storing that information. So we've just gone ahead and done it without any sort of permission, really, so that we can quickly identify patients for clinical trials or surveys and things like that. Is there
you have their permission?
We have their permission. Is that built in any way to the registry?
Yeah, in what way? What are you thinking of? With what particular?
Well, could we capture that data?
Capture their email addresses?
Yeah.
What I'd say is that there are some fields within the registry data set that are kind of flexible. There's so for example, there's a patient problem. So if you decided locally that the patient problem with a particular flag or text, suffix or prefix that identified an email address, I think it's perfectly possible to customize and use the registry web tool to collect that sort of data in a specific field for your local research purpose. Whether building in a specific field for that would be possible, I don't know. But what I see is that there's some customization and available fields that you can say, right, we're going to use that field for that purpose. And there are research visits which you can flag to say those contacts will contain that particular item of data. Does that make some sense?
Yeah. John Rhodes. And then John Rhodes. Sorry.
Thank you very much. So I'm in the role of an interviewing has-been here, and I've been already sort of nagging to boredom several people about an obsession that I had from the beginning of this process, really, the importance of collecting at least one, preferably more than one, really good outcome metric. And I'm still anxious about whether that's really coming through. So much of what you're doing, very laudably, is to check whether or not you're doing the right things to the patients and with the patients. But the overriding important question really is how well are our patients doing? And one question which I suggested, which I think is lurking in the depths of this somewhere, is that on a scale of 0 to 10, how well do you feel your IBD has been controlled over the last 12 months? And it has to be over a long time period. It's not just how are you now, because if you're seeing the patient in an efficient clinic, you may only be seeing them when they're unwell. But there needs to be some simple metric like that, which could be patient-entered, and it would be better patient-entered, and then would immediately give you a snapshot. How are our patients this year compared with last year? How are they compared with next door? And give everyone a feel for whether they're doing a good job or not, and what the problems are. Without that, it's a lot of very worthy work, which I'm sure will improve practice, but you won't really know how much you've got to do doing.
The specific metric you allude to is in fact included.
I just would urge that that's given priority.
It's got its own tab. And what I'd say about that is the psychometric performance of that over 12 months, most sort of PROMS experts would have a problem. So if you were admitted 2 weeks ago with a flare of your colitis, you'll say your control's been lousy, even if you were fine for the
ask them randomly on January 1st or June 1st.
Absolutely, but that is possible. That is possible. Yeah. The logistics of actually getting that in train, ideally what you're describing would be collected on a census date, exactly as you described, via an app. And that's all possible, but it's not a functionality that can be built in from the get-go, because the technologies around doing that and the cultural change and the coordination to do that survey is quite a big ask. But the ability to do that is in the system. The question is, how would you put an infrastructure and a support mechanism around that to allow a survey of all your patients?
I would just urge you to prioritise that. It doesn't sound too difficult to me. And without that, you don't really know how well your patients are doing. You know how well you're obeying your protocols, and you don't necessarily know how good they are.
I think we've taken the point on board. I mean, there is a question of which one to use validation. It sounds like a symposium by itself, but we are acutely aware of the need
towards that is absolutely key, and I agree with that.
Yeah. One last question, sorry, just in the interest of time. John has been very patient.
Our discussion was that there's a concern that people are going to be required to enter data after the clinic, a whole pile of notes you have to go through and so on. I would urge the team to keep the whole thing as absolutely simple as possible. So the next 12 months we get patients registered onto the registry. So the patient has their details, their basic core phenotype, they've got Crohn's disease and they're a human being, put onto the system, all right? And everything else can follow. But if you get a few thousand patients into it that way, in the next few weeks or months, there seems to be real progress. I'm very concerned that we're going to end up with, well, has the patient had a 12-month colonoscopy after they start the scan? That's not even a clinical thing I ever do. So why the hell should I be bashing myself on the head for not having done it? I mean, the whole thing just doesn't, it's in danger of overwhelming itself in the detail. And it seems to me that absolute simplicity, you want the fact that patients have IBD, some kind of IBD recommended what they've got, is it colitis possible, what sort of disease is it? And something the key can then access those patients onto the HEADS data and pull the system to start to put it together. And we can build on it. We can put these things in. We can have a VEST study that asks about particular things, which is a special sub-study. But otherwise, we're going to have registrars up all night filling in data because they know they've got an assessment coming up, and actually the data quality then goes down. So
that's fantastic. That's the exact ethos, right. and that Occam's razor, paring it down to what's actually achievable, and then moving on to surveys of how patients.
John's thing, even simpler than John's thing, which may not be validated of how they feel, would be: are they in steroid-free remission? I mean, if you can record that, that's have they got a disease? Are they in steroid-free remission? And are they alive?
John, I mean, good question. It's a good point, and it actually allows me to summarise and to thank you all, because we're actually over time. But your points are well taken, and I have the answer, which is that this is a transition year that's moving from audit to using the registry web tool. As such, our particular aims for the end of the year are to have all of your patients on biologics registered on the system, and for you to be prospectively entering data on new starters on biologics. We will report the KPIs that have specifically been mentioned. There are 6 of them. That is it, John, for this year. After that, once we get the culture change that actually shows that data can be entered, backfilled, and prospectively maintained, we will address this in bite-sized chunks in the years to come. Fraser?
Can I just make one very quick point? One of the concerns here was that, oh, it's too hard to get the too hard to get the web portal running. It is not. This is a very simple process that we can help you with. I think it's also something we haven't done is acknowledge Stephen Granger, who put a huge amount of work into developing the web portal and bringing his unique skill set to its evolution. So I think it's important that we acknowledge Stephen's contribution as well.
I completely agree, and thank you for that. I think we need to bring this to a conclusion because we're running over time and I'm presuming on your availability. So thank you for coming, thank you for your input, and we look forward to seeing you again soon. Thanks very much.